speculi for the WAXscope are more or less complete, and we are in the process now of just having them manufactured for distribution. I haven't uploaded a video with the WAXscope for a while. It's just, as many of you know, there's many other things going on at the moment within the field of audiology and within our profession in the UK, so I've just been really busy with that. But I felt I'm overdue one, so I thought I'll upload this. This is a really challenging case, and these are the cases that I wanted to see how well the WAXscope would fare with. It's a patient who's a regular patient of mine. They've got a very narrow, twisty ear canal, and they simply have dead keratin, dead skin. They don't have any earwax, and what makes it challenging is that this patient's dead skin needs to be peeled not only off their ear canal but also off their eardrum. So whenever you've got dead skin keratin, you can see it's highly reflective. On some parts here, you get a bit of a reflection, and a bit later on, I'm actually going to turn down the exposure, the brightness, just to turn it down so you get less reflection. And I'm slowly peeling this off the side canal walls, as you can see, and then eventually I'm going to be peeling it off the eardrum on both sides, which is the true test, I think, for the WAXscope. When I first started performing earwax removal many moons ago now, I think it was back in 2015, I used head loops. Now, head loops, the ones I had anyway, weren't very good, I don't think, and I was limited in what I could see. I certainly wouldn't be able to perform a procedure like this using head loops. Now, obviously, there are better head loops on the market, and some are pretty decent, I'm told. I have tried a couple. So, the view you get with head loops is similar to this view. Obviously I'm very biased here because I'm the WAXscope, but I feel the WAXscope offers you more magnification, more clarity, more ergonomics. And in terms of the ergonomics, what I mean by that is, one of the things I found difficult with head loops, and also using an ENT microscope, is the constant readjustment of the microscope or my head position if I'm using the head-worn head loops. So every time the patient moves, or if I move slightly, or if I'm going a bit deeper in the ear to remove wax, I constantly have to reposition to get focus. That's where the endoscope, the iClearScope, it's completely different. It's makeup. You don't really have to do that. Once the endoscope's in the ear, I can't remember having to ever change the focus really. But with the WAXscope, because the lens is outside of the ear, you do have to adjust the focus. Now with the WAXscope, you can do that just manually by using the slider on the app. We are busy working on an autofocus, and in fact, just there, that was the autofocus there, so I can just double tap the screen and get it in autofocus. We're just having a play around with the app at the moment, so I'm not sure if the video quality is as good as usual because we're just experimenting with one of the settings. But one of the things I'm working on is the autofocus. But even regardless of that, you can manually adjust the focus with the WAXscope just by swiping your finger and slide on the screen of the app. So it mitigates it obviates the need for you to move backwards and forwards yourself with your head. You don't have to do that. Of course, you can just go backwards and forwards with the speculi, but I like having the speculi fully inserted like I am here. So this patient's got a really narrow ear, and you may have seen I had to push this through the narrowing to widen the ear canal. And once I'm there, I'd rather just keep the specular there. I don't really want to go backwards and forwards if I can avoid it, because I've got the correct position that I desire. So I'd rather just manually adjust the focus or use the autofocus. I think with the autofocus, it's not going to be 100% accurate. So it's not going to be something that always works. I have found that with the smaller speculum that I'm using here, and again I'm just using the autofocus there, I'm just double tap the screen. With the smaller speculum it's a bit more hard to get the autofocus because I'm guessing that the screen's obviously, the iPhone's finding it a bit more difficult to locate on a particular part of what it's viewing. We are just going to do some rejigging with the algorithm to see if we can make that a bit better, but as it stands I'm really happy with the way, the functionality. So just a dead skin left here at the base of the ear canal, just going to peel that away. So you can just see how clear this suction probe is. This is the fine end suction probe we're using. It's just some dead keratin at the front. We're going to gently peel this. So again, when I first started the WAXscope, probably not attempted to peel skin like I have here. You need to gain the confidence with the device that you're using, especially because I'm using an endoscope for so long. Now I'm fully trained in loose. I've got an ENT microscope and I've been trained using that by an ENT consultant. But whenever you use one particular method of wax removal, so in my case endoscope, when you revert to another one, just takes a bit of warming up really. So this is a good test. Just going to gently peel it. So you don't want to touch that canal wall because that'll be uncomfortable for the patient. So this patient has got superficial otitis externa, all this dead skin. They suffer from eczema, so we call it eczematous otitis externa. So just going to go back in, going to stretch through the narrowing, widen, dilate the ear canal, and I'm going to get it in focus in a minute, so I'm just going to double tap. There we are. Look at that for a view, that is quite stunning. If you're watching on YouTube or Facebook, make sure one of the things I've noticed recently, especially on Facebook and sometimes on Instagram, you just press the settings and make sure you select the highest quality, because it does make a difference. So patients write it, this is even more narrower at the entrance, so it's a bit more challenging. The skin, this keratin is quite sticky on this side, so they do have eczematous otitis externa, which means they have a high turnover of dead skin, and I suspect this patient is also producing less sebum, which is an oily lipid secretion secreted by the sebaceous glands in the outer third of the ear canal. These sebaceous glands are connected to the hair follicles. We also find our scalp secretes sebum to help nourish the scalp and protect the hairs. So as we get older, as patients is in 80s now, we naturally produce less sebum and also less cerements, which is the oily sweat we also find under our armpits. So the ear's drier, it doesn't have these natural moisturising factors which help to moisturise the skin. So when you have these oils and sweats and your ears produce them, they dissipate across the lining of the ear canal and the eardrum. So it provides an oily sheath, an oily film. And what that oily film does, it helps the skin that it's sitting on to retain its natural moisture. In the absence of the oils and sweats, the moisture within the skin cells, it rises to the surface and it evaporates. So sebum and cerumen help to moisturise the skin and the eardrum, preventing from drying and cracking. So obviously this patient's producing those oils and sweats anymore, so the skin becomes dry and very itchy and cracky. And also what the oils do, they're acidic in nature, so it helps to inhibit harmful bacterial fungal growth. Also, the acidity is also believed to help to repel insects. So it helps to keep, it's a natural insect repellent, keeps your ears able to do that naturally without you having to spray anything around your body. So, and also the oil and sweats help to repel, because they're hydrophobic, they help to repel external water, so it prevents the maceration of the skin. If the skin is exposed to a lot of water, it absorbs the water, the skin cells overhydrate, they expand and the skin cells then burst, the membranes break, so it prevents that. So you can just see how narrow this portion of the ear canal is now. We're using our smallest specule, which is a 3.5mm, and it's got a tapered tip. You can't over-insert because the other end of the specule is flared, so there's only so much you can enter. We just want to go past the second bend, so the second bend is just there to the right. Because beyond the second bend, the ear canal is bone, and it's a very thin layer of skin. The skin that we're peeling away is 0.1mm in thickness, and that sits directly on the bone, making the bone extremely sensitive. So we're now going into the ear and dilating it, and stretching the ear, and just adjusting the focus again, that will double tap. You can see that skin, you can see all the texture to it. With the cartilage portion of the ear canal, the outer third, that's malleable, it's flexible, it's not as sensitive, it's not as rigid as obviously the bone's completely rigid, you can't expand that. So again, now we're working closely on the canal wall, It's going to peel the skin away. Now I know some of you guys may not enjoy the optics with the WAXscope, and I get that, it's not meant to be the endoscope. So what I always do, or try and do when I upload a WAXscope video, is upload an endoscope, ClearScope video. So if you don't like this, guys, totally get it. But feel free to switch over to on my other YouTube channel to watch the ClearScope videos, the endoscope videos, which is an extra field review. On Facebook, I just upload it on one page, so you will see another video uploaded today, guys, using ClearScope. It's also another interesting skin peel. So some of you may ask why the WAXscope. So the reason for the WAXscope is the endoscope is very difficult to use for some people because it requires bilateral integration. You need here you've got the speculum to stretch and straighten the ear canal, and the speculum also helps to steady your hand. So I'm holding the WAXscope in my left hand, so it helps to steady it. So again, we're just peeling the skin directly off the eardrum. So again, I'm very pleased with how I was able to do that with the WAXscope. So a lot of people find the endoscope difficult to use because you don't have a speculum, so you're having to keep your left hand steady, or your non-dominant hand, that's what you hold the endoscope in, because your dominant hand is always holding the instrument. And also to stretch and widen the ear canal, you're also having to use the endoscope. So there's three things you're doing with the endoscope. You've got to keep it steady and still. You've got to stretch the ear canal wide open as well with it to insert the instrument. So in this case, I've just curled the tip of the fine end to get better access to the front part of the ear canal. And also you've got to make sure the endoscope is it's angled and towards the wax or the dead skin, whatever you're removing with the eardrum. So there's three things you're having to do with that, whilst also simultaneously removing the wax with your dominant hand. So with the WAXscope, you just get the view. Once you've got the view with the speculum right here, and you stretch the ear canal, you can almost pause with that hand. You don't have to think about it because the speculum it's stabilised everything. But of course, when you're using a specula, you're going to have a reduced field of view, as you can see. And because the lens is outside of the ear, the view is probably more magnified and detailed, as you can see. We can see a lot more detail with this compared to the endoscope. Although the endoscope does give you good detail, but you lack that field of view. So for me, the WAXscope isn't designed to replace the endoscope. It's an alternative to someone who's not able to use the